keratosis present in the clinic, so it's important to recognize the systemic features here. But firstly, I'd like to start with diabetes, because this is probably one of the most common afflictions of the cornea, which is a common systemic disease. So what do we see in diabetes and what are we looking for? Well, the common features that we find in the cornea, I just listed here. So among the things that we look for are SPKs or superficial punctate keratopathy, persistent erosions, corneal hypothesia or hypoesthesia or reduction of sensation of the cornea, PEDs, corneal edema, and secondary factors like poor blink rate resulting in dry eye diseases. So the common findings that you will see in this kind of a disease is PEDs and epithelial defects like I showed here. Both of these are in a diabetic patient, and I'd like to share with you one case that we came across recently. This is a 37-year-old male with type 1 diabetes since the last 15 years, quite uncontrolled, and to add to it, he's an alcoholic. So he came to us complaining of a whitish spot in the left eye since the last month and blurring of vision with pain, redness and watering, and he also had similar complaints in the right eye since the last week. So the anterior segment evaluation I'll go through in the picture, and if you look at the picture of his right eye, this is the cornea, and you'll see there is an area of thinning in the periphery here, and you'll see that the conjunctiva that is surrounding that area is sort of lusterless, it's not shiny. This is the picture of his right eye, and then a picture of his left eye also, which has an area of thinning in the inferior part of the cornea with evidence of a past perforation. So what do you think is going on in this patient? He's a diabetic, so that's the clue. So the differential diagnosis at this point of time was we probably were dealing with some sort of a PUK, which might be infective immunological, might be dealing with exposure keratitis because of the location of the lesions, or you might be dealing with dry eye. But PUK, we investigated him systemically, he did not have any abnormality. Exposure, he had very good bells, he did not have any lag-ophthalmos. Dry eyes, his tumors was 30 and 28. So what was the explanation for what we were seeing? So take a look at this video. This is actually a video that is running, and this video is approximately 30 seconds long. And at the end of the video, maybe one of the postgraduate students is going to tell us what they see abnormal in this video. So keep looking at the patient, and what do you notice?
No blinking.
Absolutely. So he's hardly blinking. So you look at him and he's like very, very comfortable with his eyes open. This video runs for almost 45 seconds, and for 45 seconds he's absolutely the same. So this basically is a patient who has very, very poor blink rate. So if you have a patient who has uncontrolled diabetes, they tend to get sensory neuropathy. This is something that we don't realize in the clinic because we look at patients directly on the slit lamp. If we look at patients from a distance and we talk to them, we'll probably understand the fact that decreased corneal sensations also result in some sort of negative feedback that results in a poor blink rate, resulting in exposure keratopathy and keratinization of the surface. Again, very simple, very intuitive, but something that we will not really realize often. Management, very simple. We just use lubricants. We did a tarsorrhaphy for him, and within a week after tarsorrhaphy, you see that the lesion in the right eye was almost resolved. And similarly, we did a TABCL, and we did a tarsorrhaphy, and the lesion in the left eye also resolved very quickly. So simple management for something that actually